lesson, we will learn about the two main classes of bronchodilators that we use clinically. They are adrenergic or sympathomimetic bronchodilators and anticholinergic or parasympatholytic bronchodilators. These classes of bronchodilators will be useful as you work on your research project 1. The first category is adrenergic bronchodilators. One of the most common examples is, of course, albuterol sulfate. We use this category of bronchodilators for relaxing the smooth muscles in the bronchi and reversible airway obstruction. The respiratory conditions that they are used to treat are asthma, both acute and chronic, and allergic and non-allergic, such as stress or exercise-induced, bronchitis, emphysema, bronchiectasis, and other obstructive airway diseases such as cystic fibrosis. Most of the adrenergic bronchodilators that we use are for acute reversible airflow obstruction and are considered rescue agents or relievers. Examples include albuterol, as mentioned, known as brand names Ventolin and Preventol, levoalbuterol or Xopenex, and metaproterenol or Alupent, which is no longer on the market. Long-acting agents, which are used for both nocturnal control of symptoms and for maintenance bronchodilation, are called controllers. Examples of these include salmeterol or Ceravent, formoterol or Foradil, aformoterol or Brovana, indacterol or Ericapta, and aldaterol or Stavardi Respimat. They are also called LABAs, which stands for long-acting beta agonists, since they work on the beta-2 receptors in the lungs. The prototype for sympathomimetic or adrenergic bronchodilators is epinephrine. We use its racemic form for control of airway bleeding during endoscopy, or to reduce swelling in post-extubation stridor, epiglottitis, croup, and bronchiolitis. Since it is not beta-2 specific, we use it with caution, as it also stimulates alpha and beta-1 receptors, which increase heart rate, blood pressure, and other unwanted effects. The alpha-1 stimulation of vasoconstriction, however, does help with both swelling and bleeding. Sympathomimetics can further be divided into 3 main categories. They include catecholamines, which are first generation, resorcinils, which are second generation, and saligenins, which are the most recent generation. Catecholamines mimic epinephrine and cause not only bronchodilation but tachycardia, increased blood pressure as mentioned before, as well as glycogenolysis, which is the breakdown of glycogen to glucose, muscle tremor, and central nervous system stimulation, which often manifests as agitation, sleep disturbances, or anxiety. They actually stimulate all of the adrenergic receptors and are not selective. Since they are inactivated by the gut and liver, they are usually administered either nebulized or injected. They are ultra-short-acting, often lasting only 1.5 to 3 hours, and are easily inactivated by heat, light, and exposure to air. We will not spend time with resorcinils since agents in this category are no longer used for bronchodilation. The last category of sympathomimetics we will discuss are saligenins. Albuterol is probably our most common agent in this category and can be given as a nebulizer, metered-dose inhaler, syrup, or in tablet form. Saligenins are very beta-2 specific, therefore avoiding some of the pitfalls of alpha and beta-1 stimulation. Albuterol is considered short-acting as it peaks in about 30 to 60 minutes and lasts about 4 to 6 hours. Levoalbuterol or Xopenex is often used for those sensitive to albuterol, as its side effect profile is very safe, lowering the chance of increased heart rate or tremors. It is also considered short-acting. Our long-acting beta-adrenergics, or LABAs, include extended-release albuterol, which lasts 8 to 12 hours, salmeterol or Ceravent, which also lasts about 12 hours and can be used in conjunction with a corticosteroid, which we will discuss in future lessons, formoterol or Foradil or Performist, which can be given SVN or DPI and is used for asthma in children older than 5 years and exercise-induced asthma and COPD. Aformoterol or Brovana, which is used as a maintenance treatment for COPD, and asthma not controlled with inhaled corticosteroids. Indicaterol or Ericapta, which is also used for maintenance of COPD. Aldaterol or Stavardi Respimat, again used for COPD maintenance. And lastly, vilanterol, which is ultra long-lasting and is combined with corticosteroids such as fluticasone and marketed as Brio Ellipta, or with ameclidinium, a long-acting anticholinergic, which you will see as Anora Ellipta. LABA should only be used with controller medications such as a corticosteroid and only by patients who are not controlled by a corticosteroid. Since patients may have the side effects of tremors, increased heart rate, CNS effects, fall in PaO2, reactions to the propellants or additives, and sometimes a tolerance to bronchodilation, known as downregulation, patients should be monitored for peak flow rates, heart rate increases of 20% or more, monitoring of ABGs, glucose and potassium, and correct use of delivery devices. The last category of bronchodilators we will take a look at are our anticholinergic or parasympatholytic bronchodilators. Anticholinergic bronchodilators are primarily used for maintenance of COPD, although ipratropium bromide or Atrovent may be used in some patients with asthma who are not responsive to beta-adrenergics. The medications that fall into this category are ipratropium bromide or Atrovent, combination medications such as ipratropium bromide and albuterol, which is Comavent or Duaneb, aclidinium bromide or Desoroprussar, tiotropium bromide or Spiriva, ameclidinium bromide, which is Incruse Ellipta, or in combination with vilanterol, which we discussed previously, is Anora Ellipta. The prototype for all anticholinergics is atropine, which is used for symptomatic bradycardia. Anticholinergics have similar effects as sympathomimetics, except for the additional effect of drying of secretions. The most anticholinergic, also referred to as antimuscarinic, is ipratropium bromide or Atrovent. It is indicated for the treatment of airflow obstruction in COPD and is administered via MDI small volume nebulizer or as a nasal spray. In combination with albuterol, it is shown to be more effective in treating stable COPD than either albuterol or ipratropium alone. Of future interest is glycopyrrolate or Robenal, as it is used as a reversing agent for neuromuscular blockade or for drying secretions during surgery. Our long-acting anticholinergics are tiotropium bromide or Spiriva, ameclidinium bromide or Incruse, Anora, and Tudorza. All are given as dry powdered inhalers once daily for the maintenance of COPD. As a group, anticholinergics have the effects of bronchodilation, decreased mucociliary clearance, and blockage of hypersecretions, altered CNS function, pupil dilation, and increased intraocular pressures, increased heart rate, dry mouth, and difficulty swallowing and urinary retention. For those we have previously discussed, they are known as quaternary compounds. Since they are given inhalation, these side effects are greatly reduced. When side effects are seen, dry mouth is the most common, and on occasion the patient may have a cough, eye dilation, or develop pharyngitis, dyspnea, flu-like symptoms, bronchitis, or upper respiratory infection. Changes in blood pressure, heart rate, or EKG patterns are rarely seen. Anticholinergics are more potent bronchodilators than beta-adrenergics in COPD patients, with tiotropium maintaining higher PFT levels than ipratropium. It is sometimes used off-label in patients with nocturnal or psychogenic asthma, or asthma not responsive to beta agonists. As with all bronchodilators, patients should be assessed for flow rates, improvement in breath sounds and respiratory rates, pulse rate and pulse oximetry, and PFTs performed with long-term use.